Dr. Paul Bate, who's Director of Strategy and Intelligence at the CQC. And this is the last session in this work stream, so we are getting there.
Good afternoon. Welcome to the last session. I'll make sure I finish on time, if nothing else. As Amanda says, I'm Paul Bate. I'm a month into the job at the Care Quality Commission. And I'm here to talk a bit about the CQC strategy and what it means for CCGs. Look, in a nutshell, I really only want to get three things across. The first is this: the CQC is changing, and it's changing from top to bottom. We're changing the way our inspectors do business. We're changing the way all our support functions do business. The entire executive team is changing. Every sector that we regulate is changing. I'll say more about that and what the strategy has to say about that and what the forthcoming consultation document does. But the second thing I want to say is why. And we're not changing because we felt we had to in light of Francis, so that's really important, or Winterbourne View, because that's important too, or because the current government thinks we need to, although we need to bear that in mind. We're changing for one simple reason, and that's because the model is broken. The model of inspection is just broken. You can't go to a tertiary hospital for one day with two people and inform a judgment that matters to the local population and matters to the clinicians, whether it's the GPs outside or the docs and nurses and other people who work in the hospital inside. It's just not right. The model is broken. So that's why we're changing. And the third thing I wanted to get across is what this means to clinical commissioning groups. Well, ultimately, you've got to be the judges of that. But I'll put three things out there. Firstly, I think it means a much, much better information exchange. And I use exchange deliberately. We want to give you much more information. We want to give you better information. But we also need more information from you. We need the information from CCGs as commissioners. We need the information from GPs as providers. Because we are not mucking around. We are not just looking at a small block of intelligence, the data that we can easily collect, that we can take off heads. We need to know what's going on in hospitals as much as we need to know what's going on in every other sector that we regulate. But it's not just the information that I think needs to change and the information exchange. We need to give you better judgments. And we're going to move from being a compliance-driven body. We have heads of regional compliance. We have compliance managers. We have compliance inspectors. Compliance appears to be written on the soul of the CQC, but it's not about compliance. It's about authoritative, sensible, expert, professional judgment about the quality of care. So we're going to give you better judgments, and we're going to be rating hospitals, rating care homes, rating general practice, and most other services we regulate as well. And fundamentally, what I think our offer is that we want to become a regulator that you can trust, a robust, thoughtful, resilient regulator whose judgments you can believe in. So let me expand on those a little bit. Or at least try. Can you move me on? Thanks. And one more, please. Thank you. I just want to talk a little bit about what our direction is, expanding on the previous points. To give just a little bit of history here, and just a very recent history. I don't want to dwell too much on the CQC's past. But what we've just finished doing is a substantial consultation on our strategy for the next 3 years, 2013 to 2016. And this is what's come out of it. A strong, independent, expert regulator that's welcomed and valued. To me, perhaps the most important bit, we will highlight the excellent care and we will expose the poor care. We're not going to have any tolerance of mediocre care or totally inadequate care. I want to come on to that in a bit more detail when I talk about ratings, but I think that point about not accepting the mediocre is a really important point in terms of the trust of the public, and I suspect the trust of the professional community. And we will always, always be on the side of patients people who use services. And that's a really easy thing to say, but that's an important thing. It doesn't mean we won't work with system partners. Of course we will. We're reliant on our partners in the system for information. We're reliant on our partners for enforcement. There's not a lot of point in just calling that something isn't good if you've no sense it's ever going to get better. It's not our job, as far as hospitals are concerned, for them to intervene so that it get better, but there are plenty of other players in the system, including yourselves, who do have that role. We want to work with you on that. But we must always do it from the perspective of what is the right thing to do for people who use services. We have a bad track record in some respects on that. And I think the record speaks for itself. There'll be more next week, I think, just showing some of the shortcomings of CQC. But we're alive to that. We're not going to hide from it. We're going to change. So that's our direction. That doesn't seem to be working. No. So let me talk a bit about that offer that I mentioned and that information exchange. So we've been doing quite a serious piece of work about what it means to be an intelligent regulator, what surveillance means, what it means to have a view, an accurate professional view on all the different 30,000 odd providers that we regulate. They're not all odd, by the way. So one thing we're doing that's differently, just to give an example, is we're publishing area profiles so that any area can look up how many inspections have been completed and reported on and published in the last period, how many warning notices, how many other acts of enforcement are out there, how long they've been outstanding. Because we think that's useful information. If it's not, you need to tell us. But we think that's helpful. We think that's what we've been asked. So we want to provide that. But that's just one small part. As I said, I think our reports will get better, they'll get clearer, the judgments will be more robust. But the information exchange for me is really about the intelligence. We've got a basic model that I'm going to come on to in a second, a sort of operating model, but an absolutely core part of it is having intelligence, being able to intelligently monitor every one of our providers. So when people ask us which hospitals are we worried about, we're going to say every single one of them, because it would be lax not to. Of course there'll be ones that we worry about more than others, but we want to be worried, we want to know about all of them, and we can't pick it up from the hard data. I personally think the hard and soft data or hard and soft intelligence downplays soft intelligence. I think that's one of the lessons from the Francis report and Mid-Stafford. We need to know what's going on. We need to get better at finding out ourselves, but we need to reach out to people who are trusted and probably trusted more than the CQC is at the moment. So I think it's a genuine information exchange. Can we move on again, please? Oh. That's exciting. Thank you. So one of the big ways in which we're changing, in some ways this underpins all the other changes. For those of you who know about our guidance about compliance, 280-something pages, we have 16 compliance standards. In fact, we have 28, but we sort of picked 16. And they're embedded in the current legislation, the secondary regulations from 2009. And they sort of make sense individually, but they overlap, they're not clear. And we're going to change that. We're going to change it so we only worry about 5 questions. We think these are 5 questions that people can understand. We will ask of every provider we regulate. Are they safe? Are they effective? Are they caring? Are they a well-led organisation? We know how important that is from Francis and from other sectors as well. And are they responsive to people's needs? Do we know all the detail under how we will then get under that? Of course we don't. But we're putting out that those are the 5 questions. And when we consult from the 17th of June for 8 weeks, we will absolutely want to hear how people think you translate that into effective guidance for providers, guidance for our inspectors. But we're not starting from ground zero on that. We know that as far as safety goes, the Health Foundation is in the midst of an extremely large piece of work, so is Don Berwick. We have lots to build on. As far as caring goes, we know we have Compassion in Practice from Jane Cummings and Viv Bennett and others. As far as well-led goes, there's a mountain of literature. So we're not starting from scratch, but we're very, very serious about learning from others and understanding what it means to the public and to providers, each of those 5 questions, because that's what we're going to be asking. That's what's going to lead to our judgment and that's what's going to lead to our ratings. So if I try and run through as quickly as I can what's actually going to be different, let me sort of see if I can break it down into about 5 areas. The first is those compliance standards that I meant. They are yes-no judgments. If anyone looks on the CQC website, it will say compliant or not compliant. It might say not compliant with minor issues or moderate or severe, but it's basically yes or no. And it's actually quite unclear, I think, as a newbie, what it really means to be pass or fail or moderate or minor non-compliance. And we're going to move away from that compliance approach, and we're going to move to professional, intelligence-based judgment. Our inspectors will make the judgments. We are not moving to a model where the data beats the judgment of our professionals. We're moving to a model where our professionals are informed by the best possible data so they can make the best possible judgment. And we're going to have a clear system of ratings. We'll consult on what those rating levels should be. I think it'll be a 4-part rating model. For those of you who are familiar with Ofsted, I wouldn't imagine it's going to be a million miles different from that. We know that's been successful in explaining to the public what the level is of a school. And that will be driven by those 5 questions: safety, effectiveness, caring, well-led, and responsiveness. As I said, we'll go from those 28 regulations and compliance outcomes through to 5 key questions. That's simpler and able and better to understand. At the moment, CQC is part of the system with responsibility for improving care. It's legislatively we have a duty to improve or to support the improvement. But it's a conflict too, and we see that conflict playing out in some of the hospitals, where once we've looked at the action plan and we've said that the action plan's okay, what do we then do when things don't work? We say, well, you didn't quite implement it how we thought you were going to. There's a conflict there. It's implicit in both being the exposer of poor care and also improving. So starting with hospitals, and we'll see where we get to after that, we are getting out of the enforcement business. There's a failure regime, a single failure regime that already applies to financial failure. And the government said that needs to apply equally to quality failure, and has set out, roughly speaking, what that will look like. But broadly, when we've exposed poor care off the back of the intelligence and the inspections and the judgment, then it will be for commissioners, it will be for the provider board critically, it will be for Monitor and the Trust Development Authority to put that care right. We will keep saying whether we think that care is good enough or not. And we have just short of 1,000 inspectors, and they're generalists. Almost all of them are generalists. As the kind of the apocryphal week goes, day 1, Monday, dentist; day 2, general practice; day 3, tertiary hospital; day 4, breather; day 5, adult care home. It's a broken model. We can't talk authoritatively to a district general hospital chief executive if we're trying to do everything. So we will move to all our inspectors will become specialists. We will recruit in specialists. So our inspectors will be trained to specialise. And of course, a lot of them come from a health background or a social care background. But we'll also bring in lots more doctors, lots more nurses, lots more experts by experience, a programme we already have but want to build on. So we're genuinely experts in the services that we regulate. And we will spend longer, particularly in hospitals. We will spend a lot longer, we will have bigger teams, we will have broader teams, and we'll spend longer talking to patients and talking to staff. And just finally, because it's important and it speaks directly to what happened at Winterbourne View, the Learning and Disabilities Hospital, which was the scene of disgusting abuse. At the moment, we don't have powers over the boards of private providers in particular. We register managers, and there are corporate body considerations, but there's a gap, and we're going to change that gap. The legislation is likely to change subject to Parliament, and we think that's really important. We think the boards of directors need to be held to account for the quality of care they provide, not just the registered manager. Now, I don't think that's legible. We need to get better at expressing what our operating model is, but that's the best we've got at the moment. So I just want to say it's a 5-part model. Everything we do is derived from our registration conditions in law, our registration requirements. So we will register all providers. And of course, we already register pretty much all. It's only new providers or changes of ownership that we really need to register now. And then we will move into intelligent monitoring. And that monitoring will be around broadly those 5 questions. And really importantly, we will set standards. We will set 3 basic levels of standards, which of course will to some extent drive our ratings. It's not easy to explain because we don't know exactly what the mathematical judgment or conditions will be that will underlie ratings and give our inspectors a coherent framework. But broadly speaking, there will be the fundamentals of care, the things that Robert Francis talked about, and I'll talk about those more in a moment. But those are basically stopping abusive care. We don't think that's enough. We think that's hugely important, but not enough. So we will also have our expected standards. If you like, that's a proxy between what's mediocre and what's good. I don't mean that in a specific way because we need to understand exactly how we do ratings, but as a broad proxy, if you're not meeting expected standards as a provider, you shouldn't expect to be in the top 2 ratings. And we also know there's high quality. There's a difference between good and outstanding. And we look to NICE and others in the system to work with us and develop those standards, and many are already there too, including the Royal Colleges. So there will be expert inspections that look at those 5 questions, that deliver the judgments, and there will be action. In hospitals, I say it won't be from us. We'll trigger it, others will do it. It can lead to special administration. We have that power, we will have that power. But that arrow, a little black arrow, is really important. I don't think it's enough to just expose care. If people think that a bad rating for their hospital is a life sentence, I don't think that's of much comfort, particularly if you're not in an urban setting. So there has to be the sense that improvement can take place in a hospital. And that's why we think there is genuinely a cycle, and we will keep coming back and monitoring and exposing if things have improved or not. The registration element will be against the 5 questions. There will also be an added part of registration requirement that makes absolutely sure those leaders of organisations are accountable. I've talked a little bit about the information and the evidence. The piece I just want to be really clear about is just how important soft intelligence is to us, to not do it down as a word. We just aren't going to spot all the failures we need to, and we're not going to spot them early enough if we're reliant on hard metrics. We're also, for what it's worth, going to get better at the hard metrics. There's a long and involved discussion about hospital standardised mortality rates and shimmies, and we've looked at that, and we think we have a good way through that at specialty level, and that will be important. That will trigger our lines of inquiry. But it won't just be the hard intelligence, and it won't just be on clinical effectiveness. It'll be on safety, it'll be on caring, it'll be on responsiveness, it'll be on how well led we think organisations are. And as I've said, we will have those 3 standards. And the legal requirements will be both on the fundamental standards that Robert Francis started to lay out, and they'll be on our additional expected standards, which will be higher, they'll be clearer, but they will be higher, much higher than just those fundamentals and ruling out abuse. I just want to flag something for those of you who'll be kind enough to look at the consultation that will run from the 17th of June, that's this coming Monday. We don't know what the fundamentals of care should be. We don't know if they should be the same for all sectors. We want to take Robert Francis at his word. He said, don't just make them up. He then gave a list, incidentally, but he said, don't just make them up. And the government said, OK, we won't do that, but then they added to the list. So we think it will include those sorts of things: pain relief, care after discharge, a clean environment, adequate toileting, nutrition, hydration. But we don't know how to express them. We don't know what they should really be. Only the public, only providers can really tell us. So we're listening. Broadly speaking, just so I can lay out briefly what the taking action actually looks like. If a hospital isn't performing, if it falls below those expected standards, there will be space for the hospital to improve with its commissioners. That's sort of phase 1. That's what the chief inspector of hospitals will say. There will be time, 6 months, whatever it is. But if it doesn't improve in that time, then we would see something akin to special measures being enforced where monitor or the TDA are required to come in and support that change and support that improvement. And ultimately, the monitor and TDA can dismiss the whole board, or technically they suspend the whole board of the trust and place that trust into special administration, because quality is as important as finance. And at the moment we have a financial failure regime and not a quality failure regime. I've talked about the ratings, so I won't go forward on it again. But I just wanted to finish on the timescales, just so you know. From June, we have the consultation. Those named individuals at board level, that will start happening for providers of services of people with learning disabilities. By October, that will be rolled out for all providers. And that consultation will be the first of many, the one that launches in June. We need to consult on all the changes to legislation, jointly with the department, led by the department. Every time we bring in a change, whether it's to the NHS, to social care, we will consult on it. So the consultation document you'll see has an overall operating model and a focus on NHS acute services. But by the back end of the year, we're looking to do the same thing and to be consulting on general practice. And before that, we're looking at adult social care. Importantly, the ratings will start in December. The inspections will need to start before that for hospitals. So they'll be starting in October. Of course, we will learn as we go along. We will have a coherent system of ratings in place as we go forward through 2014 and 2015. And by 2016, to finish on, all NHS providers will be regulated under our new model, which includes ratings. Thank you very much. I think we've got a couple of minutes for questions.
Thanks, Paul. We have got about 2 minutes. If people have got questions for Paul, if you want to just wave, we'll send a microphone. And we've got one here at the front.
Helen Bright, leader of Doctors for Justice. We have interest in human rights issues, and there is a particular concern about protecting good providers. So, for example, in the past, CQC has accepted anonymous complaints, and some doctors, they had their lives destroyed because essentially it was anti-competitive rivalry. So I'm interested if you would be reviewing the CQC policy on anonymous complaints, which sometimes can be true and sometimes can be malicious. So it is important to distinguish between backstabbing and true whistleblowing. And while, of course, there is European framework for human rights, and the UK has signed EU treaty, it has not been actually reflected in the previous CQC management. Thank you.
I can absolutely take that away. I don't know if we are currently reviewing it. What I do know is that anonymous complaints are a source of intelligence. I very much doubt we'll stop using them, but we understand also that they have an impact on the providers.
Anything else?